Bueno, en esta oportunidad, para mí es un honor poder presentar a un especialista de renombre mundial, que además de eso es amigo personal mío, y es el doctor Jordan Feld. Jordan es un hepatólogo canadiense con amplia actividad académica y científica. Fue primer autor en los trabajos de tratamiento con antivirales de acción directa publicados en New England ya hace unos años. Y hoy Jordan encabeza una de las líneas de acción en Canadá para lograr la erradicación del virus C en el 2030. Así que para mí, insisto y repito, es un gran honor tenerlo a Jordan nuevamente en nuestro Congreso, para que en este segundo State of the Art nos hable de cuáles son las políticas para lograr la erradicación del virus C con una meta no tan lejana que es el 2030. Jordan, nuevamente la calurosa bienvenida desde la Argentina. Muchas gracias.
Hola, gracias a Fernando y todos los organizadores por la invitación, y lo siento que no puedo estar con ustedes en Argentina, uno de mis países favoritos de todo el mundo, pero hoy voy a hablar sobre el virus C, cómo lograr políticas para llegar al 2030. And at this point, I'm going to switch into English because I tried very hard to do this in Spanish, but I think it's easier for everyone to understand if I speak a language that I actually speak. It was challenging, and although I've managed to do them in the past, the video makes it more difficult, so I'm going to speak in English. So here are my financial disclosures. And so what I'll talk about today is why we're talking about the subject of Hep C elimination, the ongoing burden, the tools we have to combat this virus, and then what is required to get there, from prevention to diagnostics, treatment, many more things that we need to do, and of course the need to have political will, and along with it the money to support programs to actually get to elimination. Before we move forward, I think it's important to recognize and remind ourselves and the amazing achievement and the global recognition that was turned towards hepatitis C this past year, when these three giants in the field, Harvey Alter, Michael Houghton, and Charlie Rice, I'm honored to say good friends of mine, were awarded the Nobel Prize in Physiology or Medicine for the discovery of hepatitis C in 2020. And I would really like to highlight the importance of this, not only because it's a huge achievement for them and all of those who have helped them in the field to make this possible, but I would also say that when we're thinking about elimination, particularly in the context of COVID-19, when everything that's not COVID-19 has really not been much of a focus, we should be trying to actually leverage the fact that this Nobel Prize was awarded to refocus people a little bit back towards the importance of hepatitis C. And when we're doing that, it's very important to remind people of the burden that hepatitis C and hepatitis B as well cause in terms of the global public health burden. I think this is one of those things that is not commonly recognized. When people think of the major three infectious disease global public health problems, they typically think of TB, HIV, and malaria, and certainly these are major public health burdens, but partially due to improvements in the management of these three conditions and because of the aging of those people living with chronic hepatitis B and C, we see that since 2017, chronic viral hepatitis has surpassed any of these big three in terms of the number of deaths caused per year. And if we look at the trajectory, it's very concerning that we can anticipate that if we don't change what we're doing, by the year 2040, chronic viral hepatitis could actually cause more deaths than the combination of all three of these major public health threats. And it's with that in mind, and I think we should be actually reminding policymakers and the public and other people in medicine of the importance of hepatitis B and C to really refocus them on our elimination efforts. Now, fortunately, we have the tools to really accomplish elimination, and it's because of the development of our new therapies that the World Health Organization has thought about elimination. And of course, it's with what I like to call perfectivir, where we have these remarkably effective direct antivirals that lead to greater than 95% cure rates with fewer no secondary or adverse events, without interferon, without ribavirin, fewer no drug-drug interactions, as little as a pill a day. Resistance has been much less of a problem than we thought it might be, and with durations of just 2 to 3 months of treatment. So really remarkably effective therapy. And it's with this in mind that the World Health Organization set out for this ambitious goal of eliminating viral hepatitis as a public health threat by the year 2030. And what they meant by this was to reduce mortality by 65% and new infections by 90% compared to 2015 levels. So what do we actually mean by this term elimination? Well, this is what I was very happy to see as a diehard Argentina fan. I was pleased to see that finally Messi got it done. So this was the real important elimination, but of course I jest. What does the World Health Organization mean by elimination? It's important, and just remind ourselves that this is not eradication. So eradication would be getting rid of the virus completely from the planet, and that's only ever been done for one human infection, smallpox, and it requires decreasing global prevalence to 0 cases. The important point about it is it means that you don't have to have ongoing surveillance or control efforts once it's done. So we no longer do surveillance or vaccination for smallpox, whereas elimination is a different and a lower bar of reducing the prevalence below a certain threshold. So you limit the impact as a public health problem. Now, the key here is that we still have to do a lot to get there, but that even once we get there, you have to maintain ongoing surveillance and control because otherwise, if you don't, you'll quickly have a rebound. And that's an important consideration that I think sometimes people sort of see 2030 as this end game. Unfortunately, it's not going to be the end. It's going to be just hopefully an amazing achievement, but it will require maintenance of our activities to continue the elimination efforts. But clearly, to get to either of these endpoints, we're going to need to treat a lot of people with these very effective therapies. So how are we doing? Well, unfortunately, new infections continue to outpace cures. So in 2017, the year in which the most people that were likely ever treated with hepatitis C, and very well maybe the year in which the most people ever will be treated for hepatitis C, there were an astounding 1.5 million people cured of their infection in that year. And in the same year, about 350,000 people died related to Hep C, and another 1 million people died with Hep C, but of unrelated causes. However, despite this, there were 1.6 million new infections. So you can see that the overall prevalence went down a little bit from 71 million before to 68.5 million at the end of this year. But this was in an astounding year, and still there were actually more new infections than people being treated. So despite massive treatment uptake, the overall effect is limited. And the WHO recently put out the Global Progress Report on HIV, Hepatitis, and STIs for 2021. And this is what they estimated, that if you look around the world, we estimate that only 21% of those people living with chronic hepatitis C have been diagnosed, and a paltry 13% have received antiviral therapy. And you can see that in some parts of the world, this is much worse, like in the African region. But if we look in the Americas, we're not doing really so well. You can see that this really targets the global average. Now, by the end of 2019, it was estimated that 9.4 million people had been treated, but also that there were, again, 1.5 million new infections, and still an estimated 58 million people living with chronic hepatitis C for the most recent up-to-date estimates. And when we look around countries and we see which countries are on track, we know that many countries, in fact, most countries, are not on track to reach the elimination targets. And there's been a lot of focus on trying to figure out whether countries are improving. And I'm highlighting this to show you that most of these high-income countries are still in red, meaning they're not on track to reach the 2030 elimination targets. But I'm highlighting a couple of countries here that actually had relatively small improvements that took them from, in the case of Sweden, Canada, and Germany, from not being on track to a green bar of being on track 1 year later. And what was the change? Well, I'm highlighting this to show you that relatively small changes can have very important impacts. So you can see Sweden was nowhere close to being on track. What did they do? They removed fibrosis restrictions for treatment, and suddenly they're well on track and actually one of the countries that's likely to achieve elimination first. In Germany, a relatively modest change. They introduced a national screening program and that pushed them into the green category. And in my home country of Canada, actually nothing changed. We didn't really change any of our policies at all in the country. The only thing that we did better was collect more reliable data. And this just really highlights the importance of having good data, because without good data, we can really misinterpret whether we're on track, and frankly, even when we actually achieve elimination. If you don't collect the data accurately, even once you get to that elimination target, you might not be aware of it. So hopefully more of these countries will be moving to the green in the future. Now, why is this a problem? Well, many people assume that when we got rid of interferon, suddenly this typical cascade of care going from diagnosis through to cure would suddenly get better and we wouldn't have these drop-offs. But when you look at this cascade of care from the Cherokee Nation in the United States, and this is in the DAA era, you can see they screened a lot of people, had a relatively high prevalence at 4% of antibody positive, but you can see there's still these big drop-offs in the cascade of care. Now, when we get down to here, most of the people who are diagnosed and viremic and get linked to care, you can see that they get cured of their infection. So direct antivirals really only help at this very far right side of the cascade. But in order to really make impact, we've got to move to the left side of this cascade to diagnose more people and get them into care. And when we look at across the world, consistent findings on this, that the biggest drop-offs are this initial drop-off that people don't get a test for HCV RNA after a positive antibody test, and the second big drop-off is getting to that first clinic visit to initiate treatment. So why is this? Well, part of it is that our HCV diagnosis, although it seems simple, is actually not so simple if you're the patient. So the person's got to go see a doctor, then they've got to get a requisition, go to the lab to get an antibody test, go back for the result, again, be given a second requisition to get an HCV RNA test, finally get back to the lab. And at each one of these steps, there is the risk that we lose this person to follow-up. And it's only if they make it through all of these steps that we actually get to the point of considering therapy. So it's not surprising that many people get lost along the way. Now, of course, as with everything else this year, COVID-19 has probably made this worse for many reasons. When we look at how COVID-19 affects the cascade of care, it probably has impacts across the full cascade. When we look upstream of the cascade, those at risk for Hep C infection, we've seen reduced access and reduced availability and reduced utilization of harm reduction. And we've also seen increased risk exposures with increased injection drug use, particularly in North America, where we've seen the opioid epidemic and the overdose crisis, and we've actually seen more overdose deaths in the past year than in prior years. And this again relates to the isolation and some of the other mental anguish that goes along with living through a pandemic. In addition, through the cascade, we've had reduced testing, we've had less access to labs, people either not wanting to go to labs or actually less capacity in the labs to do testing other than COVID testing. We've had a significant deferral of treatment, people saying, I'm not going to do this right now, I don't want to come see the doctor, etc. And then we've also had postponement of follow-up care, which can be devastating for people, for example, with cirrhosis, skipping their surveillance ultrasound for liver cancer. And we've certainly seen some devastating cases of people missing these ultrasounds and showing up with an advanced cancer. So early on in the pandemic, there was this nice modeling study where they estimated the impact on a global scale of COVID-19 on global HCV elimination efforts. Now, importantly, they were just looking at the impact of a 1-year delay in HCV. And of course, we now know that we're well into our second year. And although things have improved with vaccination, we're clearly not out of the woods yet. And what you see here is that a reduction in diagnosis, a reduction in treatment starts, increases in new infections, liver-related deaths, and liver cancer, and then a big marked increase in overall viremic infections. So what's going to be the final impact of COVID-19 on HCV? Hard to say, but clearly quite a significant potential impact. And if we look at COVID-19, people always focus on the negative, and certainly it's been challenging in many respects, but I would also make the case that it does present some opportunities. First, there's been this recognition of the public health approach to address an infectious disease problem, and that's really been seen nicely with COVID-19, where around the world people have recognized we need to think about this as a public health problem, and that's been more widely accepted. We've actually had pretty coordinated responses. Things were put into place very quickly, and generally, although there's been some hiccups, generally they've worked pretty well. One clear potential advantage is the expansion of telemedicine. We've seen that really across the world, where people have said we can't interact with people directly, so we'll use telemedicine and remote monitoring for care. And this is really ideal for the simplified treatment paradigms we have for hepatitis C. We've seen amazing vaccine development and rollout, really a remarkable scientific achievement, and we'd like to see some of these technologies be used for hepatitis C vaccine development. And then some interesting opportunities from the testing side. So we've seen increased testing capacity in central labs, being able to do a huge number of SARS-CoV-2 tests every day, but also some really impressive new technologies that have allowed for really true point-of-care antigen and RNA testing for the virus that causes COVID-19, which could potentially be translated to HCV. So there's clearly been challenges, and we need to be planning now to regain momentum towards elimination, but I think there are some opportunities as well. And we've just given, as one example, is allowing us to sort of be opportunistic in the face of dealing with COVID-19. So we've looked at HCV screening in the setting of COVID-19 vaccination, recognizing that many of the populations that are disproportionately affected by COVID-19 are those same folks that we're used to seeing who have a high burden of hepatitis C. Now, people, the public health infrastructure is really motivated to get these people vaccinated, and this may be an opportunity for us to engage them in Hep C care. So when these people are coming in for vaccination, they all have a 20-minute observation period after the vaccine, and this is the potential and opportunity to do Hep C screening. And we've done this using point-of-care antibody testing, and I'm going to show you a way to speed that up, as well as using a dried blood spot to collect HCV RNA or a sample for HCV RNA testing, so really no need for phlebotomy at all. And we've started to do this initially in a psychiatric hospital with very good uptake. We've tested over a few thousand people now for HCV in a relatively high prevalence population. So one way we have done this, and I would recommend considering this if you're going to do point of care testing in this setting, is to try to accelerate the process. So we've used the OraQuick test, which is the only approved point of care antibody test in North America. And this test normally is read at 20 to 40 minutes after testing, and its readout is for hepatitis C antibodies. Now, we thought that perhaps people with an active viremic infection would have higher antibody levels, and as a result, the test would become positive faster. And that was our experience. So we then went on to study this, and indeed we were right that people who were viremic had a much faster time to a positive result than people who had spontaneously cleared their infection or cleared with treatment. Now, what we saw is that all viremic individuals, and you can see this, that of these over almost 400 people tested, we had nobody who really didn't follow this rule. Everyone who was viremic, of the 227 viremic individuals, all of them tested positive within 5 minutes. So what this means is that if someone is antibody negative at 5 minutes, they might still become antibody positive. You can see some of these non-viremic individuals became positive later, but none of those folks testing positive later actually had a viremic infection. So you can tell someone, very quick turnaround, which is important in this type of setting. 5 minutes, you're negative. You don't have active infection. If you turn out to have an antibody positivity, that's sort of a marker for risk factors, but not of active infection. And then, so what we have done is then taken a sample in those who test positive at 5 minutes, within 5 minutes, because you can see some of the non-viremic people still test positive quickly, and taken a sample for dried blood spot testing to confirm HCV RNA. But I would argue that perhaps we could even move this forward further by taking advantage of some of the learnings from COVID-19. So here we've seen very rapid development of extremely useful and effective point-of-care antigen testing. So these confirm, this could be done for HCV and confirm viremia very quickly. So with SARS-CoV-2 antigen tests, these are very cheap. They read out in 5 minutes. And if you really had something that was this good and this inexpensive, you could actually skip antibody screening altogether and go directly to an antigen test to confirm active infection. Alternatively, we could really move to true point-of-care HCV RNA testing. Right now, we have things like the SAHE test, which read out in about an hour. It's not really point-of-care, but the Abbott ID Now, as an example for SARS-CoV-2 infection, gives you a nucleic acid test that reads out in 15 minutes. With adequate resources, this is likely doable. Sensitivity is rarely an issue. We only need to get down to about 1,000 IU per ml because that's going to pick up 99% of people with chronic infections. Hopefully, we can move diagnostics forward and maybe even think about getting beyond the virus. So not just testing for the virus quickly, but also for fibrosis assessment. So we need simple tools to assess fibrosis. And if we could do a point of care ALT and AST along with platelets, or if you happen to have a transient elastography machine in your office, even better, but then we could be in a very good situation where we could really speed up the whole diagnostic cascade. So even with our current tools, we could do this relatively quickly. But we could speed this up entirely if we could get rid of the antibody test. So we get rid of that, we go to a straight point of care HCV RNA or antigen test in less than 15 minutes. We do a quick test to exclude cirrhosis, either with transient elastography or a rapid ALT and AST test to give us the APRI or FIB4, and then we're in a situation where within 30 minutes, with a single finger prick of blood, people are ready to be evaluated to start treatment. And this could really accelerate linkage to care and treatment uptake, which would be critical to helping us get towards elimination. Now, can we actually improve our treatment? I made the case that Perfectavir is pretty good, and it certainly is. But one thing where I think we could be thinking about, and the technology exists now, is the idea of long-acting injectables. You can see that this has been done for HIV, where you can see that with IM injections monthly or every 2 months, you can get sustained suppression, which is equivalent to or better than daily oral medications. And this is certainly helpful in HIV, and most people prefer it, although not all, but it's a real game changer in hepatitis C, because now we'd be in a situation where you have a single shot and you achieve a cure. So it really could look like this, with a rapid point of care test with a single finger prick, a long-acting injectable, and you're done. And if we still continue to achieve cure rates of 98% or better in people without cirrhosis, you could even skip the confirmation of SVR, so a true one and done, and make it really that easy. Now, this is what I think we would need if we're actually going to get to eradication. It's definitely technically feasible, but we need the political will and the support to develop these agents. But even thinking, although treatment could be improved, we always think prevention is better than cure. And I think it's important to recognize that in this past year was the publication of a study of the first vaccine trial for hepatitis C. This used a similar approach that was used for some of the COVID vaccines, the Janssen and the AstraZeneca vaccine, both of which used chimp adenoviruses as a prime, and then in the Hep C was boosted with a vaccinia virus, and this was a T-cell vaccine. And what you can see is that this this vaccine was tested in a difficult to study population of people who were actively injecting drugs. You can see it was immunogenic, so you got good T-cell responses to the virus. And actually it did show some promise in the sense that people who were vaccinated had a much lower peak HCV RNA than unvaccinated controls. However, there was no difference in the rate of chronic infection. So ultimately, although it was well tolerated, immunogenic, and had some effect, it didn't give any overall protection. And this was a monumental effort to do this, so I would applaud Kim Page and Andrea Cox, who led this trial, for getting it done. But it really shows us that maybe we need to think about different approaches to getting to a vaccine. And this idea of actually using a controlled human infection model, particularly now that we can no longer use the chimpanzee model, is something we should think more seriously about. This has been done for many other infections like malaria, and actually recently for COVID-19. Many things to consider: the ethics, the right population, what virus are we actually going to do, and what's the endpoint? Do we actually have to follow people out to 6 months for spontaneous clearance, or do we look for protection very early? But I think given the challenges in a vaccine study, we might actually justify this type of approach. In the meantime, until we have a vaccine, we've really got to work better at prevention in terms of reducing the things that are driving infection. And certainly in North America, the big driver is still injection drug use, and that is still a significant driver here in Argentina as well. So when we think about addressing injection drug use, we know what works. Harm reduction works, needle syringe programs, opiate agonist therapy, even supervised consumption or injection sites that we've pioneered in Canada. These are effective, but they're hugely underutilized. And I would suggest that we need more innovation here as well. So when we look at countries around the world, and you look at countries that have needle syringe programs and opiate agonist therapy, what you see is there are very few countries. You can see just 4 of them highlighted here that have high coverage of needle syringe programs and opiate agonist therapy, whereas the vast majority of countries, including some very high prevalence countries, have very low coverage of opiate agonist therapy and needle syringe programs. So we're really not getting adequate harm reduction. But the truth is, particularly in low and middle income countries, this should be a major priority, because what we see here is that when you have high coverage of OAT and needle syringe programs, what you see is that you can significantly reduce the number of treatments that are required for people who inject drugs. And that saves money. So if you have no coverage here, you're way up here at high prevalence, or you have high coverage harm reduction, you really reduce the number of people that require treatment. So it saves the expensive costs of DAAs, and of course it has other benefits as well in terms of preventing overdoses, preventing other bloodborne infections. So when we put this all together and think about how people have really taken these things together and think about approaches to elimination, obviously we all want to get to a global elimination, but we really need to think a little more locally at the national or regional level, or even about micro-elimination. And although global elimination is clearly the goal, it's actually kind of hard to get your head around, and it's largely out of our control. So we really need to focus here on these more local subjects where these are more tangible and achievable. So you can do this in many different situations: the setting, like a prison or a hospital dialysis unit as an example; the population, people with HIV co-infection, people with blood disorders, a small population, but can be impactful in terms of sort of a political easy win if you can eliminate Hep C in this population; a health system, for example, the Veterans Affairs in the US, or maybe even a geographic location. So I'm going to show a few examples. The Veterans Affairs is really an amazing achievement in the US. And interestingly, this is not usually considered to be the premium healthcare in the United States. And initially, they actually balked at treating hepatitis C at all because of the cost of direct antivirals. But what you can see is they started out with over 180,000 people infected within the system. And over just a few years of rapid uptake of treatment, you can see that they reduced this by 90% and are now in the last 20,000 or so people who require treatment. And this really required well-coordinated leadership, excellent data tracking systems to track their progress, identify successes and failures, and in an iterative process, improve what they were doing. And now actually it really is a pride and joy of their system. Another example is the prison system. We know that there's very high prevalence and burden of hepatitis C among prisoners. But what we've seen is some really innovative programs led probably by Spain and Australia in terms of addressing Hep C within this population. So you can see in this study looking at 71 prisons across Spain, what they showed is they were screening people, and initially they were just had a pretty high screening rate, about 80%, very high prevalence, almost 20% of the population with Hep C antibodies. And you can see that in 2017, they started to ramp up treatment to about half of those people. And then by 2018, 2018, almost everyone was treated. And what they saw in a very short time was this remarkable reduction in viremic prevalence, going down from 11% to under 2% in just 3 years. And amazingly, in this short time, actually saw a reduction in HC-related mortality. So not just viremia, but mortality. Now, interestingly, in this study, they showed that when they looked outside of the prisons, they saw major benefits in the community because they saw decreased transmission when prisoners transitioned to outside of the prison. So this really demonstrated that cure or treatment as prevention really works. And this was a nice demonstration. And then finally, I'm going to finish by talking about Egypt, which is the country with the highest burden and prevalence of hepatitis C in the world, but also one of the countries that's doing the best job in terms of leading the way towards elimination. So you can see that over these 3 years, they looked in the Nile Delta in 73 villages. And what they did is their target population was just over 200,000 people. Almost everyone took up testing, so 204,000 people. Prevalence was high, 16% of those had Hep C antibodies. Of those, 100% went on to get HCV RNA testing, even without reflex testing, which is quite amazing. And of the people who were viremic, about half of them, you can see that most of them got treated, 91%, and then our DAAs delivered as you expect with 98% SVR. So in total, 83% of viremic individuals were cured of their infection. And when you look at these numbers, that's really quite impressive. And some key components to this were community mobilization, free testing, free linkage to care, free treatment, an important education campaign, and then working on prevention to avoid reinfection. And really this led to multiple micro-elimination projects effectively leading to macro elimination in the country. So to summarize, HCV elimination is an ambitious but really an attainable goal. We have many of the tools, but it doesn't stop with DAAs. We need better, cheaper, faster diagnostics. I think we need to push for long-acting injectable therapies to really move the needle on this. If we are going to actually think about eradication, we need a vaccine, but in the meantime, we need to improve our other prevention strategies with better utilization of harm reduction to prevent new infections. COVID-19 has certainly had major impact, but it also presents opportunities. Improved diagnostics, we can copy and use the ideas that were developed for COVID-19. Some of these technologies would apply to Hep C very well. We've got great testing capacity, and we've seen a remarkable achievement with the vaccines. Let's try to learn from that. Major successes have been achieved with microelimination, but one of the keys to this is excellent leadership, buy-in from political leaders, with then putting political will, some finances behind it, recognizing that you get good return on your investment when you actually achieve elimination. And with that, muchas gracias por su atención. And I'm very sorry that I had to do this. I couldn't do it in castellano. Next time. Hasta luego.
Hola.
Hola.
Bueno, nuevamente me presento, soy Fernando. Este año me tocó ser el presidente del Congreso. Y para mí es una alegría inmensa estar con un amigo, como yo considero a Jordan. Yo a Jordan lo conocí cuando éramos muy chicos los dos, hace 14 años.
Wow.
Y,
en el Perú.
En Perú.
Sí.
En Perú. Y bueno, a partir de ahí comenzó una amistad que empezó con la hepatología y terminó con la vida.
Sí.
Así que aquí estamos. Yo cuando tuvimos que organizar este congreso no dudé un segundo en invitarlo a Jordan. Jordan ha trabajado en forma incansable en muchas áreas, pero la hepatitis es su amor, más allá de su familia.
Sí.
Y Jordan fue quien motivó las políticas de estrategia de erradicación del virus C en Canadá, con un grupo de trabajo. Y hoy
Sí.
me dio la buena noticia de que es presidente de la Sociedad Canadiense de Hepatología, así que lo felicito. Bueno, vamos a tener un par de minutos para hacerle preguntas. A quienes quieran preguntar, debajo, sobre la pantalla, van a encontrar un un globito de comunicación y pueden escribir y vamos con las preguntas. Jordan, gracias.
Por nada, gracias por la invitación.
Quiero avisar algo. Jordan está en este momento en su consultorio haciendo consultas de hepatología.
Sí.
Y se tomó el tiempo para contestarnos. Así que gracias. Bueno, Jordan, la pregunta principal es, vos has trabajado mucho en buscar políticas de erradicación. Y creo que vos más que nadie debes saber cuál sería la barrera o qué nos limita para llegar a la erradicación y más en el 2030 que estamos ahí nomás.
Sí.
¿Qué podrías decirme de eso?
A mí me parece que realmente es el motivo político que es más importante. En los países donde están en el camino de erradicación, siempre hay alguien, o quizás algunas personas en el gobierno que están con una fuerza de la idea de eliminación. En Egipto, en la Francia, por ejemplo, en la Francia es un buen ejemplo porque hace muchos años había un ministerio de salud del país, gastroenterólogo. Y durante esta época fue la primera vez que tuvieron un programa de screening en todo el país. Y eso es un ejemplo, pero creo que es realmente importante. Aquí en Canadá estoy siempre intentando convencer a los políticos que es algo importante, porque siempre hablan de HIV, de otras cosas, pero nunca se realizan que hepatitis, que en nuestro país es la infección que causa la más cantidad de mortalidad de todas las infecciones, pero nunca puedo convencer a los políticos que es importante. A mí eso es lo más importante. La verdad es que en Canadá ni en los Estados Unidos no estamos realmente en el camino bueno.
Acá estamos en el mismo camino. Se ha trabajado, de hecho vos has estado en una conferencia el año pasado.
Sí.
El programa nacional ha tenido un
Sí.
cambio con el objetivo de avanzar, pero bueno,
y
creo que
está avanzando, pero muy
pero
lentamente.
es lento.
Sí.
Acá hay dos preguntas, una del doctor Cartier y otra del doctor Mendizábal, que voy a tratar de hacerlas dentro de la misma pregunta. El problema probablemente mayor sea aumentar la población en donde se haga el diagnóstico,
Sí.
o el screening.
Sí.
Pero eso es muy difícil de llevar a cabo.
Sí.
Y ahí va la segunda parte. Bueno, vos cómo ves esa opción, si también crees que es por política.
Sí.
Y la
Sí,
segunda
pero también es la tecnología. Creo que necesitamos usar, por ejemplo, algunos avances en COVID-19, COVID-19, que hay nuevas tecnologías para diagnosticar muy rápido. Tuvimos todas las plataformas para diagnosticar COVID-19 o COVID-19 muy rápido, con antígeno, con PCR. En hepatitis C, nunca. No tenemos realmente un punto de, point of care prueba para antígeno, ni realmente para PCR, más o menos, pero es una hora, no es 10 o 15 minutos. Y creo que podemos usar estas nuevas ideas, tecnologías para avanzar la tecnología para diagnosticar hepatitis C más barato y más rápido, y con esos quizás sería un poco más posible hacer un programa de screening muy grande. Es porque estoy de acuerdo que el problema es que hay un montón de gente que no sabe que tiene la infección.
¿Crees que la microeliminación es un camino para llegar a la erradicación?
Sí, realmente es el único camino. porque nadie puede hacer macroeliminación en un país ni en el mundo. Es importante empezar en la situación local, pero hay que, y también hay ventajas políticas también, porque puedo decir a un político, voy a hacer algo, es algo pequeño, es algo que puedo realmente hacer, y después de realizarlo, tener éxitos, después puedo hacer algo más, y puedo crecer la idea. Eso es siempre microeliminación, un poco más micro, y después todos los micros, macro. Sí, eso es.
Una last question. En Canadá, ¿quién pide anticuerpos contra hepatitis o quién hace el screening? ¿El hepatólogo?
No, no. Es los médicos de familia. Pero aquí una cosa que es importante es usar las personas no médicos, non-medical, the peers. Porque aquí el problema es las personas que usan las drogas y no quieren ir no quieren ir en los hospitales. No ver a ningún médico. Es importante que usamos point of care test, pero point of care test con las personas en la comunidad, y pueden hacer la prueba y después mandar a la persona al médico para curarlo. Eso, a mí tenemos que cambiar la estrategia para hacer el screening.
Perfecto. Bueno, nos hemos quedado sin tiempo. Jordan, te quiero agradecer nuevamente. La próxima reunión será en vivo.
En vivo, seguro.
Para seguir aprendiendo Spanglish.
Sí, los dos, nosotros dos, sí. Sí, exacto. Ok.
Muchísimas gracias. Gracias al público. Quédense, ahora vamos a hacer un break muy cortito y vamos con la apertura del Congreso. Los espero en unos minutos. Adiós.
Gracias.